Hello, I'm Professor Claire Rusbridge and welcome to this YouTube channel. In today's video we're going to discuss the neurological exam of the patient that presents with acute spinal cord disease. That is to say, the dog or the cat that is off legs. But by the end of this video I want you to be able to describe that a little bit more eloquently. So I'm going to take you through 7 important steps for assessing the acute spinal patient so that you can write accurate medical notes. Writing accurate medical notes is important, as you know, so that you can communicate to your colleagues about the animal's neurological status, so they're able to determine when they do a neurological examination if the animal is worse, better or the same. Also, by giving a more accurate assessment, you're able to give a better prognosis and treatment plan for the owner. So the way that we grade neurological injuries of the thoracolumbar spinal cord is by a 5-point system, where grade 1 is pain, grade 2 is animals that are weak but still able to walk, grade 3 is dogs that are no longer able to walk. They may have some voluntary movement but unable to take steps or be completely paraplegic. And grade 4 is when they are paraplegic and has a neurogenic bladder. And grade 5 is when they have all of the above but also have lost deep pain perception. All seems pretty basic, doesn't it? Many people have seen this before, but it's amazing how confused people can be with this, so that it's not unusual for me to receive an emergency referral for a dog with no deep pain perception that runs into the clinic. And if you don't understand why that's impossible, then this is definitely the video for you. What do you need to do the assessment? Well, a lot of people would say an MRI scan, but this is the basic equipment of a neurologist. And I can tell you this costs a lot less than buying a stethoscope or an ophthalmoscope, so we're quite a cheap service. Yes, ultimately we do have some expensive kit for investigation, but if I had to have a choice between an MRI scan and these tools would come up all the time. Because they are how I do a neurological exam, and a neurological exam is by far the most important test that you will do on any patient that you suspect to have neurological disease. So the 3 bits of essential kit for me are a bright light. So I don't just mean that old pen torch with the battery that's faded, that's in the back of the drawer. It has to be a bright light so that you're able to see parts that can't be seen very easily, but more importantly do things like the papillary light reflex. Not essential in a thoracolumbar spinal cord injury, but for assessing other cranial nerve function. A tendon hammer. How many people use scissors? Or their phone? A £500 phone, and you're using it to do patellar reflexes and as a light source. The advantage of having a patellar tendon hammer is that, a bit like a stethoscope, you get used to your instrument, so you get used to what tendon reflexes look like using that hammer. Just like you get used to when you use your stethoscope listening to what a heart sounds like. And it's a lot easier to elicit a tendon reflex with a hammer than it is a pair of scissors. And then lastly, some hemostats or artery forceps, which we use for pinching. So our first step with our animal with a suspected thoracolumbar spinal cord injury is to ascertain whether or not there is spinal pain. So I think most vets are fairly comfortable with this. The majority of neurologists will start at the back of the animal and move their way up, as you can see this neurologist doing. But some prefer to start at the top and move their way down. This neurologist isn't actually flexing the neck much. You would likely manoeuvre the neck more if you were suspicious of neck pain. Now this dog doesn't actually have spinal pain, but he is moving a bit in the video mainly because he's a little bit anxious. So step 2 is determining if the animal is able to walk independently, even if it's just a few steps before they fall over. If they're non-ambulatory, are there any voluntary limb movements? So we can see this little dog is evidently unable to stand up and take a few steps.
Make sure that I can see the legs.
However, when he's fully supported, we do get a little bit of a suggestion of what we would call hip flickers. We can see in the slow-mo here that suggests that the limbs are doing a little bit more than flapping in the breeze. So maybe a tiny little bit of movement in those limbs. Step 3 is determining if one side is worse than the other, so-called lateralization. That's important for a number of reasons. The most important one from a surgical point of view is that if one side is worse than the other, there's a good chance that the disc will be on that worst side. And so if you were doing techniques like myelography rather than MRI gives you a much more precise location of the disc material. But if you're doing myelography, you tend to go in on the worst side if the myelogram doesn't indicate which side the disc material is, which it often doesn't if the spinal cord is swollen. The other reason for knowing about lateralization is that some types of disc disease, for example, fibrocartilaginous embolism, are much more likely to have a dramatic asymmetry with one side of the body being remarkably unaffected compared to the other. And so in your general assessment, you might be more suspicious of a fibrocartilaginous embolism. If you're unsure what I'm talking about when I mention fibrocartilaginous embolism and different types of disc disease, then I recommend that you look at the video on that. This particular image is really to represent that lateralization. And what we can see here was an observation made by an owner. The owner was walking along this golf course here, and they noted that the dog was also leaving footprints, but one side was dragging far more than the other side. So this is the mark left by the dragging footprint. And we can see quite a marked drag here and only a little bit of a drag there. So this dog here has had a bleed on one side of her spinal cord, and she has marked asymmetry and lateralizations being much worse on that left pelvic limb. As we walk her up and down, you can see that she's dragging her left pelvic limb much more than she's dragging that right. And step 4 is assessing whether or not the pelvic limb spinal reflexes are intact, and also the reflexes associated with the perineum. People often get themselves tied up in knots about this part of the neurological examination. The most important pelvic limb spinal reflexes are the flexor withdrawal reflex, that is to say when you pinch the toe does the limb withdraw, and the patellar reflex, both of which are easy reflexes to do. And the bit that people tend to worry about is how you use this to localize to an area within the spinal cord. But it's quite simple. The first concept that you have to understand is that you are assessing a spinal cord reflex, something that you studied in high school biology. So the reflex requires a sensory arm. So when you hit the patellar tendon, you stretch the patellar tendon and you activate those stretch receptors. And then you have the motor part of the reflex where the quadricep muscle contracts and you get that kick. So if you don't have a reflex, then you must have damage to either the sensory arm, the bit in the spinal cord where there's that relay, or the motor nerve coming out, which is the femoral nerve, which sometimes we refer to as the lower motor neuron, because it is the motor neuron which is coming out the spinal cord and going to the muscle. So if you've lost the reflexes for that particular reflex, then you must have damaged that section of spinal cord which is up in this region here. So when we've lost the patellar reflex, then we're talking about a lesion from L4 to L5, and if we've lost the flexor withdrawal reflex, then we're talking about a lesion from L6 to S2, S1, depending on the individual anatomy of the dog. However, if we damage an area in this region, which is really the subject of this video, the thoracolumbar region, then these reflexes, this little circuit here, will be left intact, and so the dog will have reflexes. So the way that we localize this problem is if there's reflexes intact, then it's going to be in this region, and if there are pelvic limb reflexes that are reduced, it's going to be in this region. Of course, we're just talking about thoracolumbar spinal cord lesions at the moment. We're not talking about the neck, and this is assuming that the thoracic limbs are all normal. So here we see assessing the spinal reflexes in action. There is the patellar reflex, always a little tricky to get in a chondrodystrophic dog. Those that are interested, that was the cranial tibialis. And here we have the flexor withdrawal, which is absent in this dog in comparison to the patellar reflex, which is present in both sides. Some of you may have a little question mark at this point. And again, this flexor withdrawal is absent in this dog. Neurologist is now pointing out how low tone the tail is. And now they're moving on to do the perineal reflex. Just see as we tickle that area there, we can just see a little bit of a winking of the anus. And then we're coming on to do the panniculus. We're going to be discussing this in more detail in a subsequent slide, but I'm including it here because it is one of the segmental spinal reflexes you should be assessing. And we can see there that we have a panniculus and it was absent more caudally. So what was going on in this dog? We had, just to remind you, we had the presence of a patellar reflex, but the absence of the flexor withdrawal. Well, I hesitated whether to include that in this lecture, but I thought, we should include it because it's really common. This is the phenomenon of spinal shock. So in spinal shock, what you have is depressed spinal reflexes and reduced muscle tone caudal to the cord injury. So you have an injury in this region here, and you have signs that localized that region, for example, a panniculus cutoff, but you also have signs that suggest a problem here with low muscle tone and loss of the flexor withdrawal reflex. Usually the other spinal reflexes are intact in the dog and the cat. In the human, that may not be the case. And this is a physiological dysfunction of the lower motor neuron rather than a structural injury to them. It's something which occurs when you have that acute spinal cord injury and loss of that input from above. typically you get recovery of those so-called lower motor neurons, so the nerves roots as they're coming out, and that return of those reflexes and tone within hours to a couple of days. Rarely it goes beyond that in the dog and the cat. And the reason for referring to it at this point is it is very common, I would say almost usual, in the acute onset spinal cord patient that is completely paraplegic, and it can confuse people, especially if they're also confused about differentiating between the flexor withdrawal reflex and deep pain perception, which we'll come to later. So if the dog is non-ambulatory, what else do we need to do? And this is when it becomes important to do a few other tests to assess how bad the injury is. And the very most important one is assessing whether there is deep pain perception in the pelvic limbs and the tail. And typically in this we will use a stimulus which is more painful than simply pinching the toes, as you saw earlier. So this is where you may provide a very painful stimulus by pinching the toes with an artery forceps or a hemostat. What is the significance of the deep pain perception? Well, it is only lost in severe spinal cord injuries, and that's why it's only actually necessary to assess deep pain perception in an animal which is not walking. If an animal is able to walk, then they don't have such a severe spinal cord injury. And the reason why having no deep pain perception is so important from a prognostic point of view is that C fibre nociception ascends by multiple and sometimes bilateral pathways, and it decussates. So there's many routes up to the brain. And what you're looking for in deep pain perception is a behavioural reaction from the dog. So this is me doing a flexor withdrawal here, and actually the dog didn't have a very strong flexor withdrawal, but you can see the dog's beginning to flail, and there was a behavioural reaction. So I'm looking for this, not the withdrawal of the leg, when I'm assessing deep pain perception. I want to know that the painful impulse has travelled all the way up there, all the way up the spinal cord, and has reached the brain. And it can do so by very many different routes. So the painful impulse is obviously coming in to the dorsal horn. It can travel up the spinocervical thalamic tract, which is the main route in the dog and the cat and other carnivores. It can decussate and travel up the spinothalamic tract. It can travel up the fasciculus gracilis and the fasciculus cuneatus, which is a very diffuse region right through this white matter here. It can travel up the spinoverticular tract, and it can travel up the spinomesencephalic tract. So there are many routes by which pain information can reach the spinal cord, and if you have no deep pain perception, then you have taken out the spinal cord here, 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 here and here, so right across the spinal cord. And that's why we're interested in it, because it tells us that we have a very severe spinal cord lesion. So here we see the neurologist assessing deep pain perception in this dog. You can see she's using the artery forceps, and really, although the dog is fidgeting about a bit, once off, it's really not that bothered. Not bothered at all, in fact. And if you're at all confused about that, thinking, oh, maybe the dog wiggled a bit, maybe they did feel it, then compare it to the forelimbs or somewhere else and see what the reaction is, and see what the dog is really like when they're doing that. So we see doing the forelimbs here, and we can see that instantly, even though it was quite light, because the neurologist knew the dog could feel, they paid far more attention to their limb. And here we're doing it in the other pelvic limb. And we'll normally do more than one toe. Did you see her looking at the dog there? She wondered whether the dog could feel it. But she's saying no, because the dog actually yelped there. I turned the sound off. Yelped in the forelimb, that is. And then we're doing the tail. Important to do the tail as well, because the tail is obviously another limb, another route to the spinal cord. And sometimes they have feeling in their tail when they don't have feeling in their feet. And sometimes the feeling comes back to the tail before it comes back to the feet. And so it's important to assess them all so that you can monitor a change and also detect for slightly good signs, which is obviously you want to be able to give good news to the owners. So again, you see here the dog is really, although a bit agitated and stressed, is not that bothered. We compare it to the forelimb. There it instantly looks round and looks down to the foot. It's incredibly important not to confuse the deep pain perception with the flexor withdrawal. Remember, the flexor withdrawal is just a reflex, and it can actually be present even if the spinal cord is severed in the T3 to L3 region, because that little reflex will just keep happening in the segment of spinal cord that is left. And in fact, sometimes it can be quite hyperactive. You know, the dog can pull the leg, feel like the dog is pulling the leg back from you multiple times, when in fact it's just a reflex. Of course, the flexor withdrawal reflex may be reduced or absent if you have an L6 to S1 lesion, but the dog may perceive that there is a noxious insult happening to their foot. So the two do not necessarily go together, although of course with normal nociception and pain perception they would go together. So our next step is to determine in our non-ambulatory animal, because it takes that severe spinal cord injury for it to have been lost. Our next step is to assess if there is a panniculus or a cutaneous trunci cutoff. So what is that? Well, the panniculus reflex, or the cutaneous trunci reflex, was something that was evolved in quadrupeds to twitch the skin in response to an itch or another clinging noxious insult. So, for example, a fly bite. Now, when a fly bites you, if you shake, then it's not going to necessarily come off. Whereas if the skin twitches, as we can see so dramatically when you have fly bites biting horses or other quadrupeds, then that fly will be more likely to fly off. And so a panniculus or a cutaneous trunci reflex is where you pinch the skin and you get a twitch. It is a reflex, but it's not a simple sensory arm going to motor arm. There is a bit of a relay. So we have the twitch going to the skin, and then that relays up to the C8 to T1 region. It decussates. And so you get a twitch in both sides of the animal. It's stronger on the side of the insult, and that is the muscle twitch is innervated by the lateral thoracic nerve, which comes down to the region of the cutaneous trunci to activate that muscle and cause that muscle twitch. Because each dermatome is very much associated with each segment of spinal cord, this means that when you get the cutoff in that twitch can tell you the level of the spinal cord injury. So it's really very handy in that respect. So if I get no twitch, no twitch, no twitch, no twitch, and then suddenly there is a twitch, then I know that the spinal cord injury is at this level, or maybe slightly above, because the nerve does travel caudally. I wouldn't say that the panniculus is absolutely true every single time, but it is a very good rough guide that you can have for localizing that spinal cord injury in those more severe cases. So here we can see it in action. So we have no twitch, no twitch, no twitch. Ah, there we go. There we go. Very definite twitch there. And so the neurologist is now feeling the rib. Presumably her hand is there on the last rib so that we can tell where the level roughly is. There. At the thoracolumbar junction, which is one of the most common sites for disc extrusions in these chondrodystrophic dogs. So the final step is to assess whether or not there is a neurogenic bladder. Again, this is in a non-ambulatory animal. Now, it may be that you won't be able to feel the bladder. Certainly if you've been presented with the animal acutely, it may not be possible to tell, but it's something always to watch in any animal that is non-ambulatory, and you can assume that if the dog has lost deep pain perception that they will have a neurogenic bladder and that you will need to manage that. So typical neurogenic bladder in the thoracolumbar region would be a very distended bladder. It would feel with increased tone. It would be difficult to express, and what you're seeing here in this image is a colleague trying to express the bladder in a dog with a thoracolumbar lesion. And if their bladder has become so distended that it can no longer contain urine, there may be overflow urination, which is basically dribbles of urine coming out all the time, especially if you pick up the dog by the abdomen and press on the bladder. Not to be confused with voluntary urination. Always ask if you ask the question, is the animal urinated, and you get the answer, oh yes, there was urine on the bed, always check that it's not just that it's dribbling overflow incontinence. So now we want to put it all together and write clear and concise notes for our colleagues so that they have a good understanding of what we found when we localized our injury to the T3 to L3 region and the thoracolumbar junction. I'm going to use the grading system that we saw at the start of this video. So, supposing that you found a grade 1 spine, you might write grade 1 spine, pain at the thoracolumbar junction. Suppose it was grade 2, then you might write grade 2 spine, dog is ataxic and has paraparesis, which is worse on the left, pain at the thoracolumbar junction. Supposing it was grade 3, then you might write, for example, grade 3 spine, slight voluntary movement of the right pelvic limb when fully supported, and you'd obviously also write if the animal had spinal pain and where that was. If it was grade 4, then you might write grade 4 spine, bladder distended with increased tone, difficult to express and overflowing urine, panniculus cut off, thoracolumbar junction, pelvic limb, spinal reflexes intact. Hopefully also after that you would be writing, and I expressed the bladder, or I emptied the bladder with a urinary catheter. Finally, grade 5 example of medical notes would be grade 5 spine, absent deep pain perception of both pelvic limbs and tail, that you cannot feel the bladder but you're going to go back and assess it later because you suspect that there may be a neurogenic bladder, that there was a panniculus cut off at the thoracolumbar junction, that the segmental spinal reflexes are all intact, with the exception of the flexor withdrawal, which you found was absent, and together with the finding of low muscle tone, you suspect spinal shock. So that ends this video. If you want to know more, like for example, what to do with that animal that you've now graded and whether or not they can be managed conservatively or surgically, then I recommend the next video in this series. Thank you very much. I hope that this video has given you a little bit more confidence in performing a neurological examination for those acute spinal cord cases that you see in practice. Thanks very much for listening, and I'll see you again in another video.